Great pleasure. Next talk here, Jane Blazeby. We are honoured. We are honoured. Jane met me at the Royal College at the RCS interviews for the social speciality leads, and we sat and had lunch together. And she told me, can I say it? She told me about a conference. She was quite rude about us. A conference she went to, plastic surgeons, and how we really didn't know anything about randomised controlled trials. And she's correct. We don't. Today, however, I'm hoping you're going to see that we are trying, and that we will catch up to them at some point. So Jane is the lead at the MRC-funded Bristol Trials Unit. So she's also one of the SSLs for upper GI as well. So Jane's part of the Bristol's Trials Unit, which is part of the Royal College Initiative, and we will have access to her. And I've already got quite a few projects that I need to talk to her about, and surgeons want us to get involved and get help. So we've got Oxford, Bristol, Birmingham, Liverpool, Manchester, and London. So over to you.
Thank you very much, and it's great to be here on a Saturday. Very good to see so many people interested. And what we're going to do is, the half an hour before lunch, is try and keep you awake and have an interactive quiz and teach you some basics about outcome selection, measurement and reporting in trials. It has been said that a trial is only as good as its outcomes. And the same is almost true of surgery. A surgeon is only as good as her or his outcomes. And so how they are actually selected, measured and reported, we've talked a bit about it with the nail bed trial, is incredibly important. And understanding the terminology, understanding the best ways of doing that, and understanding some of the science around making outcome measurement as least biased as possible is incredibly important. So what we're going to do is, you can't get into groups, is that I'm going to ask you a series of questions, and they're in groups of 3 or 4, and you're going to have a few minutes to discuss them amongst yourselves, or if you're not team players, to think about it in your head. There might be 1 or 2 here. I've done this before, it's very interesting watching surgeons in groups. And then we're literally going to discuss the answers, and I'll give you the answers. So it's going to start off sort of straightforward. There's nothing straightforward about anything, is there? So here you go, you've got a few minutes, piece of paper, write it down, you'll discuss with your neighbour, think about what actually is an outcome. I want a definition. What is a primary outcome? I want a definition. What is a patient-reported outcome? And then just to add into that, this methodological question, which is actually very important for later on for understanding outcomes and blinding. What is allocation concealment? And the good thing is I've got some real methodologists in the audience to correct me when I say something that's wrong. Go, you've got 2 minutes or 3 minutes. Okay, guys. So, right. So we're just going to run through the answers with some audience participation, and I could pick on people, but I wouldn't. So, who would like to have a go at defining what is an outcome in a randomised trial? Go on, somebody have a go. I'll have to ask somebody. Katie? Yes, Katie is from Bristol. Yes.
A measurable consequence of the treatment.
A measurable consequence of the treatment? That's pretty good, don't you think, David? Yeah. Would you give that one a yes? Yes, so the key things there, I mean, you're right, it's got to be related to the intervention, and it's got to be measurable. That is very important. We say, like that thing about the nail bed, it would be better, it will get better if we do this intervention or that, but what do we mean by getting better? It has to be measurable. So here I have a real definition. Outcome is an event, so the consequence that is either present or absent after someone has received an intervention that can be measured. So that's very important. Very important. So the next question was, what is a primary outcome? I gave you the answer to this question earlier, so over this side now, because the middle went last time.
I thought it was the most important outcome.
Yeah.
The most important event.
That's right. Ideally, and it can't always be, it's the most important, clinically important outcome that you want. But there's one more thing that I would add on to that. Yeah?
Power calculation?
Yeah, it informs the power calculation. So would you agree with me? I have to check with these guys. I'm just a surgeon, simple surgeon. So the key thing is, if possible, you want the most important clinical event related to the intervention or the difference between the 2 interventions. But the key thing is it's got to inform the power calculation. So it has to be measurable, and you need to have some information about the possible effect size. What would be the effect of this intervention on that outcome, and how you'd actually measure it, and what would be the difference between the 2 groups. But that thing about it informs the sample size calculation is fascinating, because when you look at trials in the literature, it's actually sometimes incredibly difficult to work out what was the primary outcome and how it even links to sample size calculation. So the business about nail beds and measurement of infection, my question, I don't think I saw presented, was what would be the hypothesis, which of those two interventions would lead to less infection at 2 weeks, and how much less? I don't think we presented that, but that's the sort of information a statistician will need in order to inform normal sample size calculation. So next question, what's a patient, we're over to this side, aren't we? What's a patient-reported outcome?
An event that is caused by the patient, so it's perhaps one that's identified by the patient that will be investigated.
It's Matthew, isn't it?
Yes.
So is Matthew correct? So what Matthew said is that a patient-reported outcome is an event that's identified as important by the patient. Is he correct? No, it's not correct, you're right. So what is a, sorry Matthew, what is a patient-reported outcome? Back to the middle team. So what Matthew said is identified as. Correct. Correct. Yes. So the key thing here, and that's right from the person in the front row, that a patient-reported outcome is something that is reported by the patient themselves. So it could be, in Matthew's situation, a patient might say the most important thing is cosmesis at 1 year, but actually a surgeon could come along and measure cosmesis, and that would not be a patient-reported outcome measure. The patient-reported outcome measure would be the patient's report of what it looked like. So it has to be something that comes from the patient themselves, as opposed to what we think about how they feel or what we think it looks like is the patient's actual self-report. And that, again, it's absolutely critical. And in studies that have used questionnaires of any sort, quality of life measures, measures of health status, you need to look in the text that's in the detail which says the patients filled these in themselves. Because if somebody else fills it in on their behalf, or makes an assessment of how they're feeling and what symptoms they have, then bias, observer bias, can come in. But we want the patient to measure for themselves. So a PRO from the horse's mouth. Okay, now the difficult question. Who gets to answer this? I think this is difficult. I always have to think. But this is really important in relation to outcomes later on, and very important in relation to randomised trials. What is allocation concealment? Go on.
Okay, so if randomisation is the method by which the study or investigator is blinded to which group the patient is going into, then allocation concealment is the method by which the investigator is not privy to the way in which randomisation is to be performed, so that they can't surreptitiously influence.
I would say you're right, but I wouldn't use that word blinding in that definition. David, what do you think? Are you listening?
Well, I thought it was quite a good stab at it, to be honest.
So this is really important. So the thing that historically in the world, if you like, that most often goes wrong with surgical randomised trials, they've labelled themselves as randomised trials, is the randomisation process itself. That's what most people get wrong. And there are two key things about randomisation that means that it is a valid randomisation process, i.e. it creates two equal groups of patients with similar baseline characteristics so you can compare outcomes. One is the sequence generation of the randomisation. So the sequence generation has to be done properly. And the second thing is that you have allocation concealment. And what it means, and you're right, just don't use the word blinding because it confuses people. So what it means, please correct me if I'm wrong, is that the person who is involved in randomising the patient is unable to actually look at the sequence generation, so they don't know what's coming next. Is that right?
Well, it depends on how you interpret it. I mean, you could actually use blinding in that context.
Yeah, but I think we just think
because the allocation to either group has been concealed, and when it is concealed, whoever's looking at those,
they're sort of blinded.
They're sort of blinded.
But the word blinding often gets confused with this, which is why I wanted to bring it up. Go on, questions. This is really important because you've got to be clear.
Is this a future or is this the present patient?
Your patient comes along.
Blinded by. So it's not.
Forget the word
the future. It's what's happening now.
Yes.
So it's which of the two arms the patient is allocated to, and
so the patient comes along, you check their eligibility criteria, they're under 16, they've got a nail bed. Oh, they look like they're eligible, they've signed consent and all that. And then you go into your computer and start randomising them, and you can't tell what's coming next. So you're effectively blinded to what's coming next. If you had a pile of envelopes, In theory, you could actually open and close them and look to see what was coming next, and that's the danger. There's not necessarily allocation concealment if you have envelopes, because you could sort of look and people think, oh, I don't think they'd be better off with a repair. So you don't know what's coming, so they have an equal, in your mind you don't know what's coming until you've actually randomised them.
Yeah, and the purpose of doing it, remember, is to remove bias.
The purpose is to remove your bias that might have this gut feeling, which we're taught to have gut feelings, aren't we, about what would be best for patients. The problem is that they don't produce science in terms of comparing outcomes. So the purpose is so that they get an equal chance of being randomised properly, and you can't actually select them in any